on, but that helps. Good afternoon, everyone. Have a second go. Welcome to Grand Rounds. My name's Tom Farden, and I'm Chair of Grand Rounds today. Thanks so much for coming. There may be some more people will sneak in as time goes by, but this Grand Round is focused on postgraduate training. Postgraduate training's changed a lot since I was a young lad. I'm officially old, I discovered this week. I tore my rotator cuff, and I went up to the physios. They said that is an old man injury, so I'm now officially old. And it is 17 years since I was a house officer in Englandshire, and my choices for what to do as a house officer were very straightforward. I was either going to be a surgeon or a physician, and once I made that decision, I just sat my paces and see how it went. And by the time I passed my paces, I was doing a chest job, so I became a chest physician, and that's about as much guidance as I ever got. Things are more complex, I think it's fair to say, these days, and have changed a lot. I'm pleased to introduce my boss, Graham Leese, who's going to come and talk about the changes to the physicianly part of training, particularly the earlier stages. And Graham is the National Lead for Broad-Based Training, which is going to explain what it is and why it's going to be a benefit to us. And then Alistair Moses, who's TPD for Higher Specialist Training in Surgery, is going to come and talk about the changes to the surgical training program. Okay, so Graham, off you go.
Good, thanks Tom. Just the mention of paces makes me feel old, so I'm sure it makes Tom MacDonald feel even older, does it, Tom?
The first ever diet of paces.
Right, this is what I'm going to talk about today. I'm going to talk about items 1, 2 and 3, and Alistair's going to talk about surgery and how shape of training, SOT shape of training, how that's affecting that. So I'm going to first talk about broad-based training. Now, broad-based training is a completely new programme to Scotland that will be starting in 2018. So it's brand new. It has been occurring in England and Wales, and we'll come back to that. So what is it? Broad-based training you do after you've done your F2 year, and if you're appointed, you do 6 months of paediatrics, 6 months of psychiatry, 6 months of medicine, and 6 months of general practice. And within each of those 6 month stints, you do 10% of your time, i.e. 1 day a fortnight, in one of the other specialties. So if you're doing paediatrics, you might do a day a fortnight in psychiatry, or if you're in general practice, you might do in medicine. So it doesn't have to be a day a fortnight. It could be half a day, like a clinic once a week, or it could be a 2-week stint of work. But roughly 10% of your 6 months spell will be spent in one of the other specialties, and we'll come back to the reasons for that shortly. So I see a few grim faces about the 10% swaps. Is actually the feedback on it is really positive from England and Wales. It gives you an opportunity to catch up on areas that you perhaps didn't do. For instance, if you're doing paediatrics first of all, and then you get 10% of paediatrics in your third block when you're doing something else, and then it gives you a chance to catch up on the things you haven't done. Conversely, it gives you a taster into what you might want to do when you're doing your main block. It gives you opportunity to develop subspecialty areas. For instance, if you were doing general practice, you might want to go and do a cardiovascular risk clinic as part of your medicine 10% whilst you're doing paediatrics or general practice. So that's the advantage of 10% swaps. And as I say, it's proven on feedback from trainees to be very popular. So why apply? What is broad-based training really offering? It's really offering the opportunity of a broader experience in a wider number of specialties. Trainees that have gone through broad-based training describe that it's a much more better integrated. They get better understanding of what other specialties are like, especially because it involves a bit of primary care and secondary care. A lot of trainees, as we know at Foundation 2, don't really know what they want to do. It's a significant number who go abroad because the options in the UK training are limited as to what they can do if they don't know what they want to do. And a lot of trainees that have ended up in broad-based training have said that if it wasn't for broad-based training, they would have probably gone abroad. So this gives an opportunity to spend a bit more time thinking about what they might want to do in certainly these 4 specialty areas. And once they've got into broad-based training, they can then go into any of the 4 specialties without further interview. So 1 entrance, 4 possible exits for them in the 4 specialties that they're doing. And part of the thing that's driving this is what we'll come back to, which is shape of training. The need, as they've said, for specialist generalists and generalist specialists. So it helps address some of those issues. So, in a little bit more detail here, you can see that if you go into broad-based training, you have your 6 months in year 1 of these specialties such as core medicine and psychiatry, year 2, general practice pediatrics. This is your 2 years of broad-based training. And as I've said, you can then, after that, go directly into any of those 4 specialties. So you can go straight into CT2 for medicine in your 3rd year, and then you would have to go into competition for higher specialty training post in whatever specialty you wanted to do. You could alternatively go into core psychiatry, straight into year 2 of core psychiatry, which is a 3-year program, and then open competition into high specialty training for psychiatry, which is a further 3 years. Alternatively, you can choose to go straight into year 2 of general practice, which is usually a 3-year program, so it would be 2 additional years. Or finally, you can choose to go into pediatrics, which is a run-through program. So there's no further competition, no further interviews at all before you get your CCT if you choose to do general practice or pediatrics, which takes you right through to the end of pediatrics. What requirements are there as you go through broad-based training? If you decide to do medicine, and you do need to have your part 1 by the time you get into CT2, as you would if you'd done CT1 as opposed to broad-based training. And you need, for pediatrics, you need the foundation of practice as advised but not essential. And psychiatry, there's the Part A exam, which is essential, and these other bits of the psychiatry exam are desirable but not essential. And in GP, you don't necessarily need any particular exams at that stage. You will be doing them at a later stage in your GP training. So, broad-based training, 1 entry, 4 possible exits, and it gives you the 2 years to decide. As I say, you go directly into the 2nd year of your next stage of training. So what do people actually choose or have chosen from England and Wales? These are the exit years, probably the most recent years, the most relevant one. So just over half of these broad-based trainees go into general practice. About just under 20% go into medicine and pediatrics, and somewhere between about 5 or 8% go into psychiatry, and there's a smattering of people that do something else completely different. So that's not, that's not a problem either. You can go and do surgery if you want. You'd have to go into core 1 of surgery, but that is an option. Does it work? This is the feedback. Actually, broad-based training has had a better assessment of its program than any other training program that exists. There was a detailed study from the University of Cardiff looking at the training of broad-based training and feedback from trainees. And these are a few of the comments that they came up with. Again, a positive comment about this 10% time in other specialties as you go through. Positive comment about just having a little bit more time to dwell on your career before you decide what career you want to do. And again, the breadth of training that you get is also seen to be a positive, both during the time that they do it and subsequently in terms of breadth of mind and integration, understanding across specialties. So what's next? The broad-based training curriculum is about to be, or program is about to be advertised. There will be interviews for that on the 27th of February next year. You do have to go through a GP interview as well as going through a broad-based training interview. There will be 12 places in Scotland for broad-based training. In the health boards shown there: Glasgow, Lanarkshire, Tayside and Highland. If there's no, maybe the odd younger trainee here, there are sessions in the deanery to come and quiz me about it more if you want, next Thursday and next Friday at 12:30. You are welcome. That's just for open discourse and discussion as you may want. So, moving on, second item, shape of training. Hopefully you've all heard of shape of training, which has been in the back burners or the front burners for quite a long time now. The main specialties that it's probably going to impact on are general medicine and general surgery. Shape of training, the philosophy of it is a need for increased generalists. There's a feeling that we've become too specialised in our training, and that postgraduate training needs to adapt for this. Medicine also needs to be sustainable with changing roles during our careers, as we're all going to be working till at least 70, probably, the younger ones of you anyway. Some of the other ones too. So we're all tasked with being able to manage acutely ill patients. Consider how training arrangements are going to be coordinated and changed, and we must have a flexible approach to this. It's also going to impact on continuing professional development for both trainees and consultants. There's talk about credentialing, which is about specific tasks and criteria, training criteria, which currently may be part of higher specialty training, but in the future may come out of specialty training and be expected to be delivered as consultants. So these may be highly specialised bits of your specialty, like ERCP or something like that. So that moves us on to this is the physician's response to the shape of training, which is the new internal medicine curriculum, which is going to start in 2019. And this is roughly what it's going to look like. So here we have a foundation program as it is at the moment, and that's not going to change. Then, if you want to do medicine, you'll go through a selection process and be appointed to internal medicine for 3 years. So unlike core medicine, which is 2 years, internal medicine will be a 3-year program. And during that program, you'll be expected to get your MRCP, all 3 bits of it, Part 1, Part 2, and PACES. You will then go through a selection program into higher specialty training, which will be a 4-year program. And that, for some specialties, will include internal medicine, and for other specialties will not include internal medicine. We'll come to that in a moment. Then you'll go get your CCT, having achieved your specialty certificate exam. Once you've got your CCT, you will then be appointed, hopefully, as a consultant. And if you want to become a super specialist in whatever area, then you will do what's called credentialing. Now, a lot of what I've described to you is going to happen. Some of this, especially credentialing, and some of the other aspects are still open for debate and are not necessarily defined exactly. The details of it are not defined. That's what we've just gone through. The red arrows here are points of appointment. So again, foundation, internal medicine, higher specialty training, and become a consultant. And as you can see, what goes around comes around. Internal medicine, higher specialties, specialists, the first 3 years will be called registrars, and then the higher specialty training at the moment, it's suggested that they're called senior registrars. Now that makes me feel really old. So, of the internal medicine first 3 years, there's a theme to each of those years. So for year 1, the idea of training in year 1 is that you will be based mainly on a ward, gaining ward skills in whatever specialty that may be. That may be cardiology, it may be neurology, it may be whatever. But the emphasis is on gaining ward skills while still doing clinics and acute medicine as well. Year 2, the emphasis of year 2 is on clinic work. And again, that might be within cardiology and neurology or whatever, but the emphasis is more on clinic work, still with acute medicine and some ward work. The year 3 is more different. The focus of that year is acute medicine, so that you'll be very much heavily involved with acute medicine unit, HDU, and other aspects related to acute medicine, like CCU. So they're not absolute. These are themes. You'll be doing a little bit of everything in every year, but that's the recommended general themes of the 3 years of internal medicine. So, a lot of work required, which is being undertaken at the moment with regard to reorganising programmes, causing some concern, I understand. The hope is that certainly within East Region, which is Tayside, is that the disruption will be as minimal as possible. Now, I mentioned that some specialties will be doing internal medicine, higher specialty, and some will be doing it, will not be doing it. Currently, and again this is under state of flux, is that what's called Group 1 specialties on the left here will all be doing acute unselected take. And as I said, there'll be the 3 years of IM training and then 4 years of higher specialty training. There are some specialties which are asterisks there, which may well, although again it's not finally decided, be doing 5 years of higher specialty training. Group 2 specialties on the right will not be doing acute medicine during higher specialty training. And these specialties have the option of leaving IM training after 2 years. They can do 3 years, or they can do 2 years. And there's no disadvantage to them for going on for 3 years. That shouldn't count against them when applying for higher specialty training, but they do have the option of moving on after 2 years. And again, there is a bit of flux. These columns are not set in stone, and there's ongoing negotiations at various levels as to which group every specialty will fall into. A lot of heated discussion about dermatology at the moment. Dermatology might pull out of medicine altogether and just become a specialty that you apply to after foundation. We don't know. I don't think that'll happen, but that has been mooted. So the Group 2 specialties that were on the right there, as I say, after 2 years of internal medicine, as long as they've passed the MRCP and as long as they've got an outcome 1 in their ARC-P, can then go on to a Group 2 specialty, can apply for the highest specialty training. If they want to take a 3rd year in IM, internal medicine, then they can do so before they become a senior registrar. So, there are other routes of entry. So we've talked about going into IM from foundation, going through IM1, IM2. There are other ways of getting there. There are people clearly that have gained core medicine training, got their CCT in core medicine, have gone perhaps abroad, perhaps gone to do research. So they are able to come back and complete their IM3, go straight into IM3 year, as long as they've got their CCT and CMT2. There is entry for international medical graduates, as there is at the moment, through schemes like the Medical Training Initiative, through which the colleges sponsor. There is a potential entry to IM3 from other specialties, depending on what skills they've gained already. And that's, again, an area that is changing and likely to change hugely. And as you know, there are other entries into medicine through ACCS, and of course now through broad-based training. So there'll be a fifth way into that. So IM4 and beyond. So all Group 1 specialties are dual accredit. So there will no longer be two curriculum for them to follow. The internal medicine will be integrated within renal medicine, cardiology, respiratory medicine. And the parts of internal medicine that they're expected to achieve through their higher specialty training will be embedded within that specialty curriculum. Another change that's going to happen is what's on the curriculum. So we're going to be moving within medicine. I think medicine's the first area to move in this direction towards competence in practice. At the moment, there are a lot of competencies to sign off, both causes frustration to trainees and trainers. It's a bit of a tick list. It's a huge number. They all have to be done. There's various methods to assess these things. You have to link the data, and it's a little bit unwieldy. So the idea of competence in practice, if it works, is to move to smaller number but broader competencies with hopefully easier sign-off for everyone. So these are the first 9 competencies in practice. Again, I don't want you to go through them in detail. These will be fleshed out. And there's another 5 there, which are a bit broader, higher level competencies. And then within each of those competencies, there'll be 4 levels. So that at foundation, you might be doing, or IM1 anyway, you'll be doing level 1, and then by the time you get up to your 5th, 6th year, hopefully you've got to level 4, where you can be trusted to do this unsupervised. So each of those 14 competencies, you'll be moving through your 7 years from level 1 up to level 4. At the moment, there's a bit of a challenge, I think, if you look at the details to how to get evidence for the higher level criteria of criteria 10 to 14. So there's a bit of work to be done about this, and so it may be a year or longer before this is fully introduced, but it will be, I think, and you'll be hearing about CIPs instead of other things. So the CIP, hopefully lighter workload, more holistic, reflect the real world, and hopefully it's simples. And my last slide, which I've been told I have to put up being an endocrinologist, is that there is a Scottish Careers Day for Diabetes and Endocrinology, which, if you're wise, is a specialty that you will do, on the 16th of November from 2 o'clock to 7 p.m. So if you're interested in a potential career in diabetes and endocrinology, it's in the Improvement Academy at Nine Wells Hospital. And at that point, I'm going to move over to Alistair on surgical aspects of shape training. I think we'll take questions at the end. Your slides.
Right, thank you, Graham. So I'm Alistair Moses. I'm a general surgeon, which of course is one of the 10 surgical specialties, and I'm training programme director for general surgery in the east of Scotland. So, process of surgical training, this is more or less as it is. If we forget about the far right where it says specialist training, currently if you wish to be a surgeon in the United Kingdom, you go to university, you become a foundation doctor, and then beyond that, surgical training is 2 years of core surgical training, followed by specialty training in a chosen specialty such as general surgery or neurosurgery, and that will last for 5 or 6 years. And at the end of that, there will be a CCT, completion of surgical training. Now, the final box doesn't exist officially, but Graham has alluded to it within medicine as well, that increasingly there is an acceptance that people with a CCT in surgical specialties will be safe to be on call in that specialty, and they will also undertake independent elective lists. But it is unlikely in the current era that we live in that someone will go straight from a CCT and go and do Operation Z, in their specialty, which might be, say, a Whipple's procedure or a low anterior resection for rectal cancer in a male patient or something like that. There is clearly now a degree of there is clearly now a time at the end of CCT, either once someone is within consultant practice or actually before they take up a substantive consultant post, at which further training is required if they wish to become a super specialist in their chosen discipline. Now, currently, most surgical specialties have uncoupled training. So what that means is essentially a trainee goes into core surgical training, and there is obviously a national selection process for that. And core surgical training does tend to be broad-based, although you can define a particular type of surgery that you're interested in and have a sort of themed core surgical training program for that. At the end of that, there is further selection in uncoupled training programs into specialty training. And at the end of that, obviously, there is a CCT exam. So, are there problems with surgical training currently? Well, something that is vexing, obviously, the people who are in charge of surgical training in the United Kingdom is too many of the core trainees are going through a core training scheme and then not progressing to ST posts. And we currently have a situation in the United Kingdom, several specialties, general surgery included, have vacant ST posts. In other words, there were 1.5 applicants last year for every ST post in general surgery in the United Kingdom, but there was also a bar set at national selection that had to be got over in order to become an ST trainee, and not all these posts were filled. And even going back 2, 3, 4 years ago, it would be an unimaginable situation that would be the case. Also, it is well recognised there's an imbalance of service commitment versus training, particularly for the core trainees. There is also over-demand in some specialties. Nowadays, sitting on the ARCP committee for the East of Scotland, it is clear that a lot of trainees want to be ENT surgeons and plastic surgeons, and there simply are not enough consultant posts in the United Kingdom for these specialties, whereas obviously other specialties like general surgery are now undersubscribed. So GMC love their trainee satisfaction surveys. Currently, as you see, surgical trainees in general are less satisfied than most of their contemporaries in other specialties. Here's anaesthetics, which is obviously a nice sunny day specialty. And the trainees in general practice are the happiest. Whether they remain so 20 years later is debatable. But if we actually split the GMC survey up into the different grades of surgical trainee, perhaps not surprisingly, foundation trainees in surgery and surgical specialties are not so satisfied. But there's a clear difference between the core trainees and the specialty trainees. And another aspect that we have to look at, but something that may be driving part of this, is most trainees in emergency surgical specialties are on emergency rotas. They're not on traditional on-call rotas. This refers to full shifts, but I think really it's just meaning a shift type situation. Trainees will spend some of their time doing emergencies on night shift. They'll spend some of their time doing extended days and weekends, which again almost invariably is emergency practice. And in green is where they actually have normal daytime shifts, so they're doing elective practice. And if you want your trainees in the current era to spend greater than 50% of their time doing elective daylight hours practice, then if you come across here, you actually find that they have to be on a 1 in 10 rota. Any less number of trainees than that, and they will not be doing greater than 50% of their time in elective activity in that specialty. Now, the focus surgical-wise, we're perhaps behind the physicians in driving this forward, but essentially the decision has been made to target core surgical training in the first instance as the part of surgical training which does need to be improved. Currently, core trainees enter a programme and they have an indicative duration of 24 months. The majority of these trainees will have got in via national selection. And in order to successfully exit core training, they have to gain the MRCS exam, Parts A and B. Improving surgical training, IST, is basically the name that has been addressed to a move to try and improve core training. So there will be an alternative surgical training model trialled from August 2018. It will not replace core training will still exist. Pilot sites have already been identified in England. Scotland is another of the pilot sites, but the hospitals within Scotland that will be piloting have not been defined as yet. And the pilots will recruit at a level of trainee who would normally be entering into year 1 of core training, and it will be aimed solely at general surgery as a specialty initially. So, the aim of IST will give a better balance between training and service delivery. At the end, it is envisaged the trainees will have exactly the same set of clinical and technical skills and competencies that their contemporaries do. And the key is that the pilot will be trialled and to look at an improved delivery method and an improved environment for training. So this has been driven or is being driven by Health Education England, and Scotland is sort of going along behind, tagging along. So Health Education England has said that it wants to redevelop the concept of the firm, which has been lost obviously through modern sort of routers and the way that we staff our units. 2015 report from the Royal College of Surgeons of England said that the dissolution of the firm had led to the loss of the traditional relationship between trainee and trainer. And I think most of us can appreciate that, and I suppose the phrase continuity of care and the importance of that in actually training has been lost. So currently things are slightly in the ether as to how all this will actually take place. As I say, it is a pilot currently that's proposed for August 2018, but comprehensive monitoring and evaluation plans are in progress. They wish to assess whether the trainees have benefited from the changes, and they also want to look at the impact that the pilot will have on the variety of outcomes from trainee satisfaction to service delivery. The pilots will initially focus on the 2 years of core surgical training. There will be pathways, however, to let trainees out into standard core training. In other words, you might get into general surgical core training on the IST project. You might feel actually you still want to be a surgeon but not a general surgeon. You are allowed out. You're not actually, you can get back into normal core training if you so wish. If parts of the project are successful, it's hoped to spread them out to other specialties within surgery, and it's an aspiration that the changes may be rolled out over the full duration of surgical training and not just core training. An aspiration, as I say. So, actually looking more specifically at the recommendations, what they want, and if a hospital or a trust in Scotland wants to engage in the project, they will have to make sure that at least 70% of the working time that the doctor has is between 8 o'clock and 1800 hours. Such trainees will have to be on rotors which have a minimum of 10 people on them, And it's also envisaged that a non-medical workforce will be required within part of the on-call rota at core level to facilitate this. They want competence-based progression with clear targets, with a minimum and maximum duration for the training. They talk about enhanced selection. The trainees on the pilot, once they get to the end of year 2, they don't have to reapply for general surgery ST. It will be run through. And they talk of enhanced assessment and an ARCP process. So enhanced training, more time for training, enhanced trainer training, the SPA equivalent for an educational supervisor for a consultant looking after one of these trainees will rise to half an SPA rather than the current 0.25. And it's envisaged that the trainees will spend longer in individual units, so there will be an enhanced apprenticeship, more like the old model. Surgical curriculums are currently being modified, and it will take account this. There will be a broader base of training. There will be more emphasis on the entrustable professional activities, which the GMC are keen on. There will be more emphasis on simulation training and surgical boot camps, where trainees go away for, say, 3 days to Inverness, as it is in Scotland, and spend time doing surgical simulation. They have also, the Royal College of Surgeons of England have also suggested there will be surgically themed FY2 attachments. And coming back to my second slide, at the end of, I've tacked this on to this, but at the end of CCT, they also want to have national selection for subspecialist fellowships. So, in summary, there is perceived to be a problem with surgical training in the United Kingdom, and particularly with core training, which reflects in part an imbalance between service and training. Colleges, JCHST, Health Education England, are attempting to resolve some of these problems with a pilot training programme for general surgery, and the pilot will commence in August 2018.
Good. I think now might be the opportunity to open this up for any questions that you may have. Yeah.
Hang on, I'll get...
We've got the Roma.
I was just going to ask, with a CMT replacement, are you tied in to a subspecialty at the beginning of that?
No.
So all the way through, even if you complete all 3 years, you're not tied in?
Correct. So you apply, when you decide to leave IM, you can do any higher specialty. So if you decide to leave after 2 years, then you can only go into Group 2 specialties. If you stay on for 3 years, then you can go into Group 1 or Group 2 specialties.
Great, thank you.
Good question.
The haematologists.
Haematologists and
Group
rheumatology.
2. Thanks. When Shape of Training, Graham, was first kind of mooted, a lot of it was all about the fact that most people in hospitals don't need to be there, they should be cared for in the community. And it was kind of envisaged that you'd have general physicians looking after patients in a community-based setting rather than in the acute hospital. That seems to have been ditched altogether now then, is it? That's not the vision of it now, it's all around the model
I've not heard much talk about that.
Care.
I've not heard much talk about that. But having said that, are there any geriatricians here?
Because I think that's good news if that's ditched, because we could never imagine anyone who'd want to do these jobs, and they would never be attractive.
There are people starting to do these types of jobs under the banner of geriatrics, so community geriatricians to do that kind of role. So that is happening. I'm not aware it's being pushed by Shape of Training, but some health boards, I know in Glasgow, are actually going down that route.
Someone in Perth has a question.
Hi, Alan.
Things that go around come around, and I agree with you about applying for a registrar job and then applying for a senior registrar job, but it's like, down to years ago. But anyway, going back to the original shape of training report, there was very much a theme of starting with training, broad-based training amalgams, and then maybe doing your exam, and maybe doing 5 years, and then coming out of training and having a service post to do some unsociable hours, to man the front door, to be on tape for medical and surgical units, and then do higher specialty training or accreditation, depending on the wishes of the trainee and the needs of the service. Now, it really isn't very much like that, what's left, and as you describe it. Is this definitely what's going to happen and agreed across the 4 departments of health, or is there still some uncertainty about either?
You're right in terms of what the original vision was. My understanding is that original vision really has been watered down into the things I was talking about earlier. So I think what I described earlier is what's going to happen. There are some details, like what happens with dermatology, that still need to be finalised, but broadly speaking, what I've suggested is going to happen. And IM1 will start in 2019. So the only other role I'm not entirely clear in my own mind as to what the higher specialty training trainees will be allowed to do in general medicine, but I think that's still to be defined. Jay.
I'll run over here.
What is the main driver for this change of training? Is it to accommodate the service provision, or are we saying that the training so far is useless?
The number of years, as you see, is going to be roughly the same. The main driver comes from shape of training. It's to get more generalists. I think there was a feeling that there were too many specialists, and the number of generalists was decreasing and the need for generalists was increasing. So it was to address, I think that was the primary driver, or certainly that's the primary driver that's persisted. There were other drivers initially, like trying to get people through training more quickly, but as you say, that's been ditched really, because the number of years for training is the same. And in fact, for some specialties, might be longer.
Graham, the profession has for a long time fought against the junior consultant role, a 2-tier consultant grade. But the shape of training programme will push out generalists, and then after a CCT, and then on your flow diagram it says there will be credentialing to become a specialist. Do you think this is going to lead to a 2-tier consultant grade and effectively junior consultants?
Yeah, the whole aspect of how much of your super specialty stuff you do as a consultant through credentialing and how much you do through your training program, well, that's one of the details for each specialty that still needs to be defined. So I think it's difficult. If there's a huge amount of credentialing, then it may drift in the direction you suggest, but there's been a real push against that, so that actually there may not be much credentialing at the end of the day, in which case there'll be less of this drift towards perhaps a 2-tier consultant level. Of course, also the BMA and certainly NHS England are looking at the consultant contract. That's a different issue altogether, and that might impact on what you're talking about.
And one final thing, perhaps you could just remind us, Group 1 specialities, that there is a year where we won't have to go and do interviews because we won't appoint any ST3s. Which year is that? And perhaps
that'll be currently at 2021. There will be no entry into higher specialty training, because that'll be where the transition from a 2-year to a 3-year core-ish program will impact on us. So in 2021, there will be no advert. You have a year off your interviews.
I don't get a year off. I'm TPD. I have to deal with them all. And GIM doesn't disappear if you're a registrar or thinking of being one in medicine. GIM will still be a thing, which we'll still have to manage. Okay, any more questions, comments? Then I will...
Any surgical questions?
Yes, surgical questions. Does anyone want to be... Any questions about surgery?
Any questions about broad-based training?
No.
If you do know of any trainees that are interested potentially in broad-based training, you could advertise the fact that there are open discussion sessions, as I said, next Thursday and next Friday lunchtime.
It does seem amazing to people of my generation, and I'm sure of Graham's as well, that there was a desperate fight to get a registrar job. It was even getting SHO jobs were so competitive, and it was a real struggle to get a job. And now there's 1.5 applicants per post, and then there's only 0.7 of them are appointable, and there are all these empty posts lying around. It's a real change from what I experienced as a trainee knocking on for 20 years ago. On a more positive note, I should remind you that nominations are open for FAME Awards. If you are aware of a fantastic medical educator, please nominate them for a FAME Award. You should have had an email today. If not, posters will go up and I'll send it around, because Jordan will send me the details, if it's Jordan that does it. Is it the students? Yeah, well, somebody will send me an email, I'll send it all around. Please nominate people for FAME Awards, okay? And I will see you next week for the next grand round. Spontaneous round of applause for our speakers. Thanks so much. See you next week. Oh, and buy an Archie book. That's the other thing I was going to say. Buy an Archie book for Christmas.